Um, I want to go ahead and mute myself. And I guess everybody else just kind of stay on mute until you're speaking, but let me get mine.
Hey Beth, how are you doing?
Good morning.
Hey Robert, thanks for joining us.
Good morning.
We have just a few more minutes, so we will hang out here and get started at 10.
And Katie, I can go ahead and put the poll up, and it starts as people enter, and then it'll go away if you want me to do that.
Yeah, sure.
Okay.
Abby, we need to tell Cindy that we need a hair and makeup team for our community television events.
Yes, that would be awesome.
Can you hear me? This is Ann Simmons. I have no
Hi, Ann.
idea why I don't know why my picture doesn't come up. I have never done this before, so I'm here even if you can't see me.
We can hear you very well, Ann.
Thank you.
Welcome.
Yeah, I'm a newbie.
So it is 10 o'clock and we'll go ahead and get started. I'm Katie Varnado. I'm a regional director here at Partners, and I serve Burke, Catawba, and Rutherford counties. And so welcome to our monthly community cafe. And this month we're going to be talking about Medicaid transformation and how that has impacted people differently from different parts of our healthcare system. So I would like to introduce our partners team that's facilitating this cafe with me. We have Jeannie Patterson, who is a community trainer, Jerry Campbell, who's system of care specialist, Amber Matthews, who's also a community trainer, Carla Bradshaw, who is with our gas team, and Abby Cole, who is helping us with our IT from our marketing department. We do have a survey that's popped up on your screen with 2 questions. Which of the following best describes you, and what county are you representing? So if you will take a moment to select an answer with our survey, and we can actually share those results and get a glimpse of who we have joining us this morning.
You ready for me to share? I'm Katie.
Yep, if you're ready.
Okay.
So we have 5% community members, 9% educators, 36% providers, and 18% stakeholders. And then we have 59% representing Burke, Catawba, Cleveland, Gaston, Iredell, Lincoln, Rutherford, Surrey, and Yadkin, and 18% representing Cabarrus, 9% representing Forsyth, 5% Union, 5% Stanley, and 5% other. So thank you all for joining us all across our region, and welcome to Cabarrus and the other counties that are joining us also. So I want to take a minute to let you know, Jeannie and Amber will be responding to Q&As in the chat box. And if you need to raise your hand, Abby can help get you unmuted if you need help. And this is an open dialogue, so we want it to be as conversational as possible. If you have any questions that come up as we're speaking, this isn't necessarily a webinar or a formal presentation as much as a community conversation about how Medicaid transformation is impacting us. So feel free to raise your hand or put a chat in the chat box at any time. We can also share some links with you if we mention anything that you'd like more information about. Please don't hesitate to put that in the chat box or reach out to any one of us, and we'll be glad to help get more information about it. And so first up, I'd like to give you an update about partners and how Medicaid transformation is going for us. We were recently awarded a state contract to manage a tailored plan, and that will go live July 1st of 2022. So right now we're in the planning phase of making sure that everything is ready to go as of July 1st, 2022, and really developing our strategic plan for what that looks like so that it will be a smooth transition, and working with our community partners and helping get our members and beneficiaries into the right plans. So I'd like to introduce Leanne and Tom. Leanne is with Contegra Health, and I'll let her tell you a little bit about what she does.
Hey, good morning. So I am with Contegra Health. I'm Leanne Richard, and I am the Director of Population Health and Case Management. I oversee the panel managers, which are LPNs and RNs that are embedded in all of our clinics, our primary care clinics. And then I also have the CMARC and CMHARP programs that report up to me.
Thank you, Leanne. And Tom, would you like to introduce yourself?
Sure. Hey, everybody. I'm Tom Martin. I'm a pharmacist. Hard to say who I work for right now. I really don't know. I'm working as an independent consultant right now for a couple of different groups, primarily in the Medicaid transition space for the last year and a half or so, but worked at Baptist Hospital in CMC, Maine in Charlotte for 25 plus years doing inpatient critical care. Got to see what happens if people don't do what they need to do every day to take care of their blood pressure, blood sugars. So I got to see that in for a long time. And then I jumped out to the outpatient space about 11 years ago or so with CCNC, and worked with the Cleveland, Rutherford County area, part of CCNC, primarily as a clinical pharmacist doing hospital transitions, helping patients get their medicines when they leave the hospital. And in that model, of course, we were embedded in clinics too, like Leanne was talking about. So it was nice to be able to go to the appointments with the patients, to hear the plan, and then kind of help the patients walk that out. And then the last 2 years since the transformation occurred, CCNC kind of went away, and I've been working with a local group here in our Cleveland County area. It's basically a safety net provider, a primary care PCP, independent PCP, doing home visits. It's kind of like old-fashioned medicine. Of course, COVID threw a wrench in the home visit part, so that's been interesting. But the last probably 6 months to a year, I've been primarily focusing on the transition. Done some consulting work with some of the new providers, some of the new payers, to help them figure out how Medicaid functions. And that's what we're going to talk about today, kind of how the transition to 5 payers has changed kind of the landscape a little bit.
Thank you, Tom.
Yeah.
And to speak to that, what was the inspiration for this community cafe is that when we ask, depending on who you ask, Medicaid transformation is impacting all of our organizations differently. If you ask a primary care provider, they might say one thing. If you ask pharmacy, they might say another thing. If you ask the beneficiary, they might say something else. If you ask juvenile justice or our county stakeholders, they might say something completely different because they're helping serve individuals that may or may not be in the right plans, or it could be going smoothly that they've ended up exactly where they need to be. And we have to look at it from both the financial, the health finance aspect of our providers contracted with everyone that they need to be, or from the person's perspective of, are they trying to see their primary care doctor, but that primary care doctor doesn't take the prepaid health plan that they're signed up with. So there's a lot of different perspectives that we can look at to really get a good image of how Medicaid transformation is going for our communities. So with that being said, Leanne, do you want to talk a little bit about that, about how it's impacted the people that you're serving in your organization?
Sure. So I'll start with patients first. So, which is one of our core values, patients first. So we have found that with our patients, that a lot of our patients were auto-assigned. And so getting them changed to where they want to be with the right provider, the right PHP, we have to direct them directly to the broker. And that has kind of thrown a wrench in not being able to assist the patients where we assist them with other things, getting them assigned. We're not allowed to with this. We have to assist them with a broker, which when the patient's in the clinic, that's not always time. There's not always time when we have a provider waiting to see that patient to assist getting the broker on the phone and then trying to assist with that changeover to whichever PHP they want to be assigned to. So there was a large number of patients that were auto assigned instead of being able to select themselves. They didn't make that choice, and so they were auto assigned. So that has been something that we are constantly trying to address and help patients with. So patients, and then on our end, trying to make sure that our organization is aware of all the changes that need to happen. And so keeping them informed has been part of Go Live. We have constantly been sending out newsletters. We have on our website, we have a link with all the links to the different PHPs that they can directly go to that. And it has all the information that they need in one location, which has also been helpful. The biggest issues that we have seen has been prior auths and dealing with 5 PHPs with 5 different portals. So that really has been trying to make sure that all the people that need the access to the portals have access, which that means a different login and a different, for each one. So that's been, we really were struggling the first couple weeks to make sure that everybody that needed that access was granted that. So you have to have somebody that's in your organization that manages that, granting them access and getting them all linked up. So that was one of our biggest issues during Go Live. And then knowing what needs prior auth, because we didn't need prior auth with certain procedures. One of the things that we found out, because we were under the understanding that dental was carved out, and then all of a sudden when we went live, we found out that dental procedures needed prior auth. And so there were procedures that were being canceled because there wasn't a prior auth. So we kind of wasn't focused on dental because all along we thought dental was carved out. So we didn't know how that was going to impact us. So that was blindsided us a little bit. So those are the ones that I can think of off the top of my head that were the things that kind of we had struggles with at Go Live.
Have you had any like general feedback from members about how the process has been with them?
With patients?
Yeah.
Yes, the patients are confused. They don't understand how it's going to impact them. I think that they are excited about the additional benefits they get. And so trying to determine what, they're looking at those to determine which one is the better plan for them that applies, because some have maybe unlimited chiropractic visits. So that may be more beneficial to them versus a plan that has a GED, or other things. So all of them have different perks along the way. So them trying to navigate that to really determine what is the best plan for them, and without us being able to guide them on that. And I think one of the biggest issues is getting a hold of the broker, trying to select the right plan, and getting the help that they need, especially because we thought that the broker was going to be able to assist them out in the community. And then with COVID, that didn't happen. They didn't allow the broker out in the community. So we lost that resource. And the only way that those patients were able to participate or was either online or by phone, and so if those, if they didn't have access to, if they didn't have a phone, if they didn't have Wi-Fi, they didn't have access to that broker. So if they weren't in the community. So I think we lost the ability to get more patients enrolled prior to go live, and less people being auto assigned. So I think that was one of the downfalls of this, and where it kind of hurt patients as far as not being able to electively select their PHPs prior to go live.
Have you utilized the ombudsman services any?
We have, because there's the provider ombudsman, and then there's also the patient ombudsman. We have directed patients to the patient ombudsman, and we have provided that link and resource to our providers as well if they're running into any issues. So we have had to direct some questions that we've received different answers, one answer from the PHP and a different answer from the state. And so we've kind of used them to try to be the go-between to get a different answer, or to get the answer that is correct. So as our go-between between these different entities.
And since we have a large percentage of providers here with us, any of you providers that have joined us this morning, do you have anything that you'd like to add, or any comments or questions for Leanne? Anything about how it's going for you guys?
Yes. Hi, my name is Terry Howard, and I'm with the mental health services. So some of the issues that we're having is in the PHP plan, enhanced services is not covered. And if we offer them enhanced services, we have to do a move back to the MCO, LME. And so we didn't know to have prior authorization in the beginning. And so it takes about 30 days to move them back. And so we can't see those clients until they move back. Have you had any others that have experienced that?
I have assisted with someone in the community with moving someone that needed enhanced services back to from a PHP to the LME MCO, and I had to follow the process that Leanne did, and actually contact the or give the contact information of the broker Maximus to the agency. And I was told by the ombudsman that it would take about 3 days for them to switch the plan back. So Leanne, has that been your experience?
Yeah, that's been my experience. The ombudsman has definitely been helpful as far as assisting in that and elevating it. So that would be the route that I would take.
Use the ombudsman. Okay. Okay.
Yeah, I would
Right.
use the provider ombudsman. There's
Okay.
also a patient ombudsman. So there's two different ones.
Okay. Thank you.
Hi, this is Julie Walker. I'm with the Cognitive Connection, and we provide substance use disorder outpatient treatment and also have a primary care service within our facility. My question goes along with this first question. We too experienced early on that some of our enhanced SUD patients that were in either SACOT or IOP were auto-enrolled into the PHPs without them even knowing that they were auto-enrolled. And so we too have been working through to get them switched back to Medicaid Direct. It has not been a 3-day process. We still have some that are in our enhanced services that are not showing Medicaid Direct. The concern is we've continued serving them ethically. We cannot stop services with this population in essence, with their addiction issues. And so the question that I've continued to put out there is, how will we be reimbursed for these patients that have been with us from July 1, auto-enrolled in a PHP? And again, we're doing everything that we can to get them Medicaid Direct. I've heard that it will get retroactivated back to the MCO, but again, I have to report to a board, and this is highly concerning that we're getting mixed messages between the PHPs, the state, and the MCO. And ethically, we do have to serve them, and we want to serve them.
And
Are you?
Beth,
I was just going to ask, are you contracted with the different PHPs? Are you contracted with all of them?
Yes, we are.
And Beth Brooks, I hate to put you on the spot, but have you been having these conversations also?
Laverne Currents is handling our transition of care. So she probably has more details about that. So I can't totally answer that question. I would have to ask Laverne and get more concrete details.
And a lot of the, Julie, to answer your question, we would need to probably bring in provider network. So if you don't mind, if I follow up with you and get you connected to someone in provider network to get you a more solid answer about that.
Thank you so much. Yeah, we're just trying to figure out what is the best course. And again, we're following protocol. The other concern that I had was we're part of the CCPN network. And so we've had contracts in place since when the PHP started and even prior to them being put on hold. But what happened when July hit and everything went go live, we've worked through a couple of the PHPs with this, but there's 3 that we're still working with that they're saying that we don't have contracts. And it's my understanding that we have to show that we have contracts to continue to get reimbursed. We have yet to be reimbursed with our services. And again, we can show contract, but somehow the system sort of disengaged that. But again, we've had contracts since the beginning when all of this first started. And so that's another concern that I have.
And there's also, I was just going to say this also, this came out last week, I think it was last week, out of network provider payment and prior authorization flexibility, they have been extended until November the 30th, until November 30th, 2021. So if you're out of network or you're, so all that's going to be extended until November 30th.
Okay, so we'll continue working with these PHPs. CCPN is also going to, is also engaging in the conversation But again, that's just been quite frustrating because we've had these contracts in place. But thank you so much.
You're welcome.
I just want to mention in the chat, there is Madeline has put contact information. If you're having issues with Amera Health Caritas on billing, she's given you the contact information, email and phone number, if you want to look at that.
And Leanne, with the contracts, is that something that you think the provider ombudsman would be able to help with also?
With the contracts, yes, and I have some contacts with all of the PHPs that if they said that you have any issues, there's different, and I can include that in the chat with some emails if you have questions with each one.
Thank you for that.
Thank you.
All right, so Tom, are you ready to tell us a little bit about how Medicaid transformations impacted what you do?
Sure. I was glad to hear anybody really mention medications in that discussion. Leanne did mention prior authorization, so I got a little nervous. I thought she was going to say the medication PA process. But honestly, it has not turned out to be, at least from what I've seen and heard, has not been as big of a problem as I think everyone thought. The good thing is, for the first year anyway, the medication piece is kind of the same. It's still going through NC tracks, and every provider does have their own website now, their own link for the providers to use to do prior authorization. So that's created a little bit of confusion, but I think the document that they sent out at the very beginning, the first, I forgot what it's titled, but it's like the first week or the first days of transformation, had a lot of valuable information on it. It had the links to where to send your prior authorizations for medications. A couple of the small speed bumps we've run into is that the providers themselves, the PHPs, didn't really, I guess, grasp how the approved medication list worked in terms of Medicaid. The North Carolina Medicaid PDL, a preferred drug list, is quite different than anything else that's out there. If you compare the state of North Carolina's Medicaid list to other states who already have Medicaid through PHPs, our list is much longer and a little cumbersome to understand, especially around the idea that there are brand name drugs that are preferred. The idea generally is you write for the generic because it's cheaper, but in North Carolina Medicaid, there are probably 70 or so brand name drugs that are the preferred products. So if a provider writes for a product and the pharmacy tries to fill it as a generic, which they generally do, because generics are usually the preferred agent, it rejects. And some of the rejection codes the pharmacies are getting, and I honestly spent a lot of time in pharmacies trying to figure out kind of what their issues have been. And it's the codes that come back to them, telling them that a PA is required on a drug that doesn't need the PA, it just needs to be entered as the brand name product. And this is really true around in the ADHD space. There are several brand name ADHD meds that are preferred by the state of North Carolina. So if the pharmacy knows that and they just enter it as a brand, then it goes through without a hitch. But what generally happens is that it rejects. And so the pharmacy sends a cover my meds request to the provider or whatever, SureScripts, whatever. The provider gets it, and depending on the practice, some of them have people designated to handle the PAs, so they get dealt with pretty quickly and turned around, and that information comes back and it's entered as brand and everything's good, and the patient's able to get their medicine within, maybe a day. Some of the smaller practices, however, that don't have a designated person that handles the PAs, they come back as a fax. It sits on the fax or in their stack. And sadly, a lot of the practices just don't have the personnel that it takes to manage this. And this is just the medication piece. But they'll have stacks of requests for PAs or, even for procedures, things like that, it just takes a while to work through. So it may be a week before a patient gets access to their medicine. So that's really where I've tried to help streamline that and head that off as much as I can. I worked with several of the primary provider, or the PHPs, to put together the list of brand name meds that are preferred. And I tried to get them to put that on their website. So the pharmacies really will have access to that. And back in the good old CCNC days, we would send out fax blasts when the state would send out their list of the new PDL. We would send out a list to the pharmacies and say, here are the brand name preferred drugs that have generic equivalents that are not preferred. That's key. If it's just a brand name drug that's preferred, but there's not a generic, then it's not a problem. It's the ones that have a generic drug available that's not preferred that really creates the hiccup. But we try to communicate that to the local pharmacies to make sure they were aware, to kind of head that off, and to work with NC Tracks to make sure that the verbiage that goes out to the pharmacy is correct. If it is a PA problem, then to state that. If it's just a brand name preferred problem, if the alert would state that, then obviously the pharmacist could just enter it as brand and problem solved. So we've been working behind the scenes trying to get those little things straightened out. But honestly, all that was kind of in place before the transition. The difference here being obviously there are 5 companies now that handle that, and working with them individually to kind of get them up to speed with what the state has done. One issue that we run in with that is even if you use their link to do the PA, like Leanne said, they're all a little bit different. AmeriHealth Caritas, for example, I can log in for my provider and do a PA for her. Because it doesn't require you to create a separate login, like healthcare and WellCare. You have to log in. You have to create a login. And my provider works in a couple of different practices, and so she has logins there, and she has her own login. So it makes it a little bit harder because I don't know her login for those patients that she works with in bigger practices, but the individual patients that we manage, I need to log in as her to do her PAs. So that's created a bit of a headache from that side, but I'll be interested to hear from some of the providers, some of the medication issues they run into. I mean, that's been kind of the nuts and bolts of the transition piece and getting the different companies on board. The other big piece that I'll work with, and I'll talk about later, is that the hospital transition piece. When people come out of the hospital, I'm still doing home visits, so I do get to hear a lot of what the patients are saying about the transition. It's about what I expected them to say. On the other side of that is it's interesting because as I understand it, and y'all certainly can correct me, but as I understand it, the people that stayed in NC Direct didn't really get a new card. One of the biggest issues that I ran into with the practices was people that stayed in NC Medicaid Direct didn't get like a new card to say, we're starting over, here's your new card. And so when they go to the practices, all the practices would say, well, what plan are you in? And they said, I don't know. And they said, well, where's your card? I didn't get a card. And so, the first month or two, July and August, it was really just working with practices, trying to figure out how to get paid. And then the people that didn't get cards that were in new plans, when I go to their house and we're sorting through all their stuff, I'm like, well, you got to sign. If you didn't sign up, you got to sign. I'm like, I don't know anything about it. So we would rifle through their stacks of mail. And lo and behold, down in the bottom of the stack of mail, there's their welcome letter with their cards and their information. And so they were surprised to even know what plan they were with. So there is that learning curve for them. And I think, getting them through this piece, I think will certainly help some of the stuff downstream. But would be interested to know how people, what kind of problems you're running into on the medication side.
Leanne, do you have any feedback about that piece of it?
Yeah, we saw the same thing with the cards. I think we had to do a lot of education with our team to be able to recognize what the different cards look like, because the newer cards just look like a regular Healthy Blue insurance card. You have to really look at the fine print to see that it's a Medicaid card. And so trying to educate our team to know what these cards are going to look like and how that needs to be re-entered into our system and things like that. But knowing the cards was a big piece of a learning curve on our end as well.
As far as the prescribing medications, have you heard any feedback from your prescribers?
Not too much, because we had put out the preferred drug list ahead of time, so our providers were aware of that and aware of patients that were going to need some prior auths with specialty medicines. So we did a lot of education on that in advance and shared the preferred drug list. So they were, especially because all of the plans are sharing the same preferred drug list across the board. So they all, that definitely was helpful that we're not having to work with 5 different plans with 5 different preferred drug lists, that they did share and utilizing that across all the plans. So.
Yeah, that is true. And that's very helpful. And thank goodness they did. And the next year, of course, that's going to transition away from that. Each plan will take on their own responsibility for what their preferred drugs are, which I think, there's going to be a little bit of a hiccup there too, as patients in different plans find out the drug they've been on for a long time is no longer covered or preferred. So there's certainly speed bumps along the way that are ahead, but I think the first year, at least maybe 1.5 years of using the same PDL was a very good idea.
So do we have any of our stakeholders that have joined us this morning that have any questions or any contributions to what they're experiencing in the community?
Hi, this is Julie Walker again. My CFO just reminded me, has to do with provider concern. We did get reimbursement and payment through yesterday through Carolina Complete, but the claims that were reimbursed to us, they're not our patients. And so we've got big concerns with that. We will follow up with the PHP, but it's been sporadic whether or not we get someone that is able to speak with us direct. And then again, we got reimbursed for patients that aren't even our patients.
So Julie, did you see the link in there you said that was Carolina Complete?
Yes.
Okay, so there's a link in the chat for Carolina Complete. I would reach out to them at that email.
Okay, thank you. And then the only other question, is that something that we have to document for HIPAA violation or anything?
I would check with your HIM group. I wouldn't think so if you have a contract with all of the 5 PHPs.
Yeah, that was my thought, because we have contracts with all 5 of them. So
yeah, I think you're okay because you have the contract with all of them.
Okay, thank you.
I'd like to speak on what Tom Martin was saying about the cards with beneficiaries. I represent AmeriHealth Caritas with Region 1, and when we do outreach in the community, it's very often times that beneficiaries will ask them, do you have your card on you? Do you carry it with you when you go to appointments? And a lot of times they, like you said, have it in their mail. It's at the bottom of the stack. They haven't checked it. So one thing we really try to do as community educators is make a point of engaging in that conversation and asking them if they have their card, if they have found it yet, and to hold on to it with them from now on. So the conversation's being had. It's just getting that in their head that that's something to hold on to and to share with the provider.
Yeah, and like Leanne said, they don't recognize the card. Even if they get it, I've had some show me the card and just not realize that was their new insurance card. It may say, Blue Cross on it or whatever, but they just don't make that connection.
And I would also, with that, just thinking as patients will show up at our clinics and they don't have their card and we don't know which plan they're with and that kind of stuff. So we've had to add more people to our NC tracks to be able to go into NC tracks to identify which plan they're with. So that's been an addition that we've had to do as well.
Yeah, and just knowing that you can look up the plan, and I think hopefully everybody knows that, but we did have a couple of patients say the provider wouldn't see them because nobody could figure out which plan they had. So the provider should be able to determine that just by looking up on NC tracks. It'll tell you what plan they're in.
Yeah, and it doesn't take but just a second. It's real easy to do.
So my next question for you guys is, the overarching vision for Medicaid transformation was to have a more complete whole look at whole person wellness. And so do you guys see that with the other benefits that come along with the health plans? Do you find yourself collaborating more with community partners, and how's that going?
I don't think we've seen that come to fruition yet. I think we're so early in the process right now that we don't know. I think we're really just trying to get through these first steps, because I don't know that we're actually utilizing those resources yet.
Yeah. And I would agree. And I think this is one area that I'm excited about, actually. The potential here is that North Carolina Medicaid, as we knew it, really didn't offer those ancillary services that I think make a huge difference in ultimately how well a patient does with a care plan. And, being a pharmacist that works in clinics and working with patients, home visits, I get to see kind of how, or hear how the plan should be. And then I get to see how it gets walked out or not walked out. And I'm hopeful that the PHPs will start throwing some resources into that part of it. The more of the navigator plan. I mean, if you can imagine every patient having a navigator, seems unrealistic in this day and age, but we're at a point in healthcare, I believe, where it's so complicated, even with technology. And I read every day new companies coming out with patient-facing technology to help them utilize healthcare resources, but you still have to be able to use the IT to use the resource. And so we're never going to be able to, in healthcare, we're never going to be able to replace a good old face-to-face conversation, especially with our low literacy patients, which a lot of ours are. You just can't explain to them how to load Zoom on their smartphone, that kind of stuff. So, just having that personal contact, I'm hopeful that they'll pay for those resources to provide that service where it's needed. And then just things that just make common sense. And I do a lot of work with diabetes, obviously. So patients that are, well into their course of diabetes are frustrated and they're just kind of giving up. And, it's kind of, there's a lack of resources to get them back into the game to want to take care of themselves. That self-determination feature is just not there. And so who's responsible for making that happen? Providers don't have the resources anymore. They don't have the time anymore. The key word in the offices is throughput. How many people can we put through the system in a small period of time, which leaves patients without that key piece of information and encouragement, as I say. We can give them all the information in the world, but we got to give them the encouragement and the hope that they can do it and the resources to do that. And so I really feel like that's where the companies can step up and make a difference, because they're all willing. I mean, you look at the list of resources that are given to patients now that they didn't have under the old system. And Leanne mentioned some of them, the cards. They're getting gift cards. They're getting access to gyms. You can join a gym for a period of time. Yoga, I've seen some classes like that. Bus passes, our city doesn't have a bus, but that'd be hugely important to somebody who has trouble getting to their appointments in other cities. And several other things that, for that individual make sense, but for a lot of patients in the more rural areas, maybe not so much, but certainly paying for like diabetes education, for instance, or the diabetes prevention program is a well-respected, well-documented feature of helping patients manage prediabetes. And so why not pay for that? And so those are the things that I've been trying to talk to the plans about, is looking at what they're willing to pay for. That's kind of part and parcel to the overall care of that wellness. The social determinants of health is a key phrase these days. And you look at how somebody lives and you realize why they don't care about their A1C. Because when you roll up in their house and it's chaos everywhere, and you're there with your plastic fruit to show them how to eat better, they don't care. All they care about is, what's going on with their kids, their spouse, paying their bills. And so you realize really quickly that it's not just about controlling their A1C, it's about controlling their chaos enough to care about their A1C. And hopefully the plans will get behind some.
And I shared in the chat there a link to where you can compare the plans and those additional resources that Tom's referring to. And so you can click on up to 3 of those at a time and compare like AmeriHealth, Carolina Complete, and the different plans and see all the extra benefits side by side in alignment, how those compare. So that's a great resource. And we have that on our website, patient facing as well. So patients can compare as they're trying to make decisions, since they have till the end of September to continue to make changes.
Yeah, and again, that's what a navigator would help too, to help them sort through that, because a lot of those services, they don't even maybe realize that they need at that time, but it is something that they could definitely benefit from.
I'll speak on behalf of AmeriHealth. Since going live on July 1st, the biggest value-added benefit we have been requested or had requests for is the mode of care transportation to appointments and care provider appointments. And the biggest obstacle at this point we're realizing is that with mode of care, sometimes it can be the parent and the child that's going to the appointment, but there might be only one more person that can come with, and that parent might have 3 or 4 kids that they don't have childcare to bring with, So far, that's been the biggest thing we've been running into, but the transportation has definitely been the most popular value-added benefit at this point.
Absolutely.
So we are in the open forum part of our discussion. If there's anybody else that has any questions or comments, and if you don't want to speak up, you're more than welcome to put that in the chat box.
I was just going to say, during our go live, one thing that we did that was very helpful is we did a Teams call that started in the morning at 8:30 or I guess actually 7:30 and went till the end of the day. And we had team members kind of like a go live with an EMR or anything else. We were just on the call all day. And anybody on the organization could pop into the call and ask questions as they were seeing patients in the clinic. So our whole organization was invited to the Teams call, but they only needed to join if they ran into a glitch or had questions or something. So that was very helpful and worked out well for our organization.
I appreciate both of you for being on our panel today and really giving us some insight into how things are going with you. And our community engagement team, all of us actively work with our partners to help get you the resources and information that you need when you need them. Even if it's provider or member related, we can help make those connections for you where we have a no wrong door policy. So anyone on with us this morning, please don't hesitate to reach out to any of us, and we'll be glad to follow up or connect you with the right person or answer any of your questions. And so if there aren't any other questions or comments, I'd like to tell you a little bit about our community cafe for next month. September is Recovery Month, and we have events going on with our county collaboratives across our catchment area. And in honor of Recovery Month, our next community cafe will be about community recovery. So we want to connect with people that are in leadership positions in our communities that can tell us about how their experience with substance use has inspired them to do the work that they're doing in the communities, whether it's nonprofits or working in behavioral health or healthcare in general, like how that experience have led them down the path of serving our community. So we hope you join us. That'll be on the last Wednesday of September at 10 a.m. And if you've registered for all of the sessions, you'll get a reminder. And if you haven't, you can log on at our partner site and register for all of the upcoming sessions. So you can join us once a month. And I hope that you all have found this helpful and have gotten some good information out of it and some good connections. And like I said, if you want any of us to follow up, you can email me or any one of our panelists or team members, and we'll be glad to follow up and help you.
And before we go, I just wanted to mention that there are a lot of resources that the panelists and different people have put in the chat. So encourage you to check that out before you log off to see if there's anything that you might find helpful.
And Abby, you'll have to refresh my memory. Will this, if they want to follow up with any of this, or get a list, a printout of the question, the information or anything like that, will we be able to send that out to them?
A printout of the chat, is that what you're asking about?
Or the information that we put in the chat box?
We can pull the information from the chat box if you like. I'll get
Okay.
with you before we send the email with the recording, if we want to put some of those things in there, and get that out to everyone.
Okay, and everybody will be receiving a survey also to follow up. So take a few minutes and fill that out, because we want to make sure that you all are getting as much out of this as we are from your company. But if you have anything that we need to address, or any thoughts or feedback on our community cafes, please let us know, because we do want to continue to make them better for you all. And with that being said, I hope you all have a great Wednesday and hope to see you all next month.
Thank you.
Thanks.
Thank you.
Thank you, everyone.
Thank you.